Wow, well, what a great set of presentation and comments and stimulation. We could discuss for an hour or two. We have only about 15 minutes, but because we're running on time. But I welcome short comments or questions for people to come up to the microphone for any of our speakers. And I can barely see you, so you'll have to say who you are and state your brief question.
Hi, my name is Nicole Maltimore. As you all know, I'm a physical therapist. This message is for Dr. Kassler. I guess wanting to know, and I'll talk to you again after this, but going about policy change, as a physical therapist, most people see me for rehabilitation, so I'm an afterthought. However, studies have shown that with increased exercise, increased activity, people tend to do better. So, how to phrase this? How can we affect policy change in the medical field? Because, and I know I'm biased because I am a physical therapist, but being that I am the face in the community sees me. I go into patients' home. I correspond back and forth with the physicians. How can policy change where I'm not just an afterthought, but a forethought to prevent, which in time will help to decrease money spent? Because if I could prevent a person from falling and breaking a hip, I just save Medicare $70,000.
Okay, Bill, how about that one?
So I'll give you three answers, and I think you're spot on, and really appreciate the important role that you play in the healthcare team. I look to increasing evidence of the role of strength training in the elderly to keep them out of nursing homes, which will improve their quality of life, improve their independence, and save Medicaid a ton of money. And so we are looking at the YMCA and senior centers doing that, and that's exactly the wider range of services that we have to refer to and figure out sustainable funding for. The second is that there's an important role for local public health in that, in addition to the clinical care system. And the third is that with another hat, I'm the chair of my town's school board. And schools are an important piece of that. Right now, our sports teams have access to trainers and physical therapy, but we're struggling to get the non-sport kids to think about physical activity and ways of doing that keep them safe and healthy and have a lifetime of habit. So probably an inadequate response, but at least the first three things.
Thank you, and good for the time that we have, so thank you for that response. We'll go over to the microphone over here.
Hi, I'm Elaine Borowski from Case Western Reserve's School of Medicine, and I have a question that relates probably to the organization going forward. And Dr. Kindig, I mentioned this to you earlier. It seems to me one of the challenges is going to be terminology. It just struck me from this particular panel, again, we're all using the word population health here, but boy, those are really different definitions. And when we're out in the world trying to propose or to promote population health, I mean, no offense, Dr. Kassler, but your definition of population health is really different from mine. And I noticed that you had referred to sort of as the population health, you're the population health from population health management versus total population, which I don't know. So I'm just questioning, is there anything in the role of this new organization to help clarify? I know you tried to do it in the blog, Dr. Kindig, but are there plans or ways in which we can begin to help, I think, maybe clarify a little bit? Clarify or at least understand so we can promote better. Thank you.
You know, first, I can't speak for the organization, and second, with 10 minutes left, I don't think we can get into a terminology debate here. I mean, there's been plenty of discussion here today in this meeting that there are two ideas out there where an enrolled population is seen as a population health management denominator, and Steve Teutsch's total population health more at a geographic. I mean, both of those are real, alive, and in some tension and have to work together, and maybe we for now leave it at that. I do expect this organization will dwell in it in the future as it goes forward. At this microphone, please.
Yes, Mustafa Hussein at the Drexel School of Public Health. And my question is regarding Medicaid payment reform, if the CMS is envisioning something of that kind. We know that residents of low-income neighborhoods are most likely to receive Medicaid. And at the same time, there is paucity of Medicaid providers in those neighborhoods relative to need. which really potentially drives a neighborhood inequality in access to physician providers. So physicians are really upset about the Medicaid reimbursement levels and all of the administrative burden that comes with it. So is there anything in the future that gives us some hope that Medicaid reimbursement is going to change, or so I would like to hear your perspective on that. Thank you.
So the challenge with Medicaid as opposed to Medicare is that Medicare is a single federal governmental program. Medicaid, by its design, and reinforced by the most recent Supreme Court decision, is a state-based program in which the states and the federal government collaborate. We provide guardrails, but defer a lot of the operation to the states. So I think you're going to find a tremendous amount of innovation at the state level. There's work that we're doing to support the states. And given the time, we can talk offline, but it is a slower process that really is at the state level.
Okay, thank you. Again, in the spirit of moving along, we'll go over here to get a few more questions in.
Hi, my name is Mike Bader. I'm at American University here in DC, and I had a question for all of you. The precision medicine working group just put out their recommendations for a cohort, and it struck me, particularly Anna, you were talking about the need to think about disparities, but there was no effort in that within the working group to make the population representative. It was all a clinical-based sample, and so I was just wondering if any of you had any thoughts or comments on that.
Anybody want to take that one?
Well, so I think we will, in population health, we will have to think about how we're going to engage with the precision medicine movement. And I think, you know, a big thing is what exactly is precision medicine? You know, is it a euphemism for genetics in clinical care, or is it about taking into consideration the many kinds of environments that people are in, and considering those when you think about clinical care, which is consistent with the way we think about population health? I think the jury's still out on exactly what that is going to be. Certainly, it is, you know, focused on patients, and by definition, that, you know, leaves out a whole bunch of people. So I think, you know, I think there are things that there are areas in which I think population health can collaborate with the precision medicine idea and think about how we can learn something useful from it, and there are areas where we're going to have to say, well, we need to do other different things. This is really not addressing our broad view of population health. But I think I'm sure we'll have a lot more discussions on that topic.
And I would just add two things. One is 1 million patients is a large cohort, so you can begin to get some sense of a population. I was very encouraged by the inclusion of environmental exposures, but I haven't heard anything about the interviews related to the psychosocial issues. So if they intend to include that as well as the environmental exposures, I think this could be very helpful.
There is an IOM activity on genomics. I don't know if it's a roundtable or forum, and actually our Pop Health Roundtable this week is going to begin to discuss how those two activities can connect with each other and begin to explore some of these important areas. We have time for, I see 1 or 2 people. One more question for sure. We'll see how that goes.
This is Marilyn Dold. I'm from the Washington State Department of Health, and we are tasked with the Plan for Improving Population Health as part of our SIMS grant. In working very closely with local health jurisdictions, I was pleased to hear you call them out as a key partner. What we are hearing from them is that they really feel they can bring to the table a couple of valuable pieces. One is that they're used to working and they're knowledgeable about population health. They have tremendous capabilities for data gathering, and they have a health equity lens. And they're very concerned because they're not getting enough in terms of foundational public health services funding, and they do not have the infrastructure to take on the additional work that they would like to do and would make a great contribution. I wonder if those conversations are taking place at the national level.
First of all, I couldn't have said it better than you, and the answer is absolutely. We are working with our colleagues at the Centers for Disease Control and Prevention very deeply across quite a number of areas, and I think you hit upon a tremendous opportunity, but that opportunity is challenging to implement.
Thank you.
Okay, we'll take one more if it's brief.
Okay, I'll try to be brief. This question is about research.
And you are?
Sorry, my name's Sam Harper. I'm from McGill University in Montreal. We heard a lot about what we should be doing more of in terms of research. And I guess I've been thinking about how folks at the Lancet, Ian Chalmers and Paul Glazou, estimated that 85% of all biomedical research is wasted because of poor design, poor measurement, lack of statistical training, et cetera. I'm curious as to what you think that fraction is for population health research and what you actually think we should be doing less of.
Okay, that's a good one to end on. We'll take a minute or two on that.
I don't have the courage to answer that.
Don't you have all the money? You're not going to even try?
No.
Okay. Sam, that's a good question. If I'm honest, I think I think this happens in all publishing. I don't think it's exclusive to population health. I think a large proportion of the stuff that we publish is not very useful at all. And we publish it for other reasons. So I think we have to be honest about that. We do a lot of stuff to get a little amount that is really meaningful. I think we have, and in terms of what we should be doing less of, I'll give you my personal opinion. I think a lot of the mechanistic stuff sometimes does not add that much value. I think, and we may be getting at that point in terms of the traditional way of looking at mechanisms and mediation. I'm not sure that we can get much more if we continue to look at it this way. There may be other ways to look at it which might be more insightful. So that's one area where I think we need to do more of policy evaluation, natural experiment stuff, that kind of stuff.
Yeah, I would answer it just a little different way. It's probably more than more. It's more of the dissemination pathways for evidence that can reach other populations and policy populations to augment whatever are the scientific standards of the peer-reviewed nexus of knowledge. The real emphasis needs to be on the translation of usable knowledge with a reasonable evidence base in a policy sector where it can make a difference and be evaluated to what difference it could make.
Actually, I'll end on this. In the last session, the policy session before this session, we heard a call for something called strategic science, which I'd not heard that term before, but it essentially means for more and more of our work, we should go to the using communities and ask them what are the questions of importance that will really influence their organizations and then help them with the data, the analysis. That'll probably increase the percentage of useful studies, I would think. So let us thank our panel again for a great session. We could have gone on and on, but there will be, this material will be discussed over the years, and actually a plug for tomorrow, we will continue the discussion here in our Pop Health Roundtable workshop on a population health research agenda, and while they are taking their seats, I am going to invite up our concluding speaker, Mike McGinnis, who is senior scholar here at the Institute of Medicine. In the role of our new organization, he is chair of the Senior Advisory Board of IAPHS, and many of us really see him as the father of much of the population health thinking and research that we've been discussing today. So, Mike, you get to close it out.